Hello, Professor Schultz. As you know, this is about ARDS, that is acute respiratory distress syndrome. So it's being considered as an established thing, low tidal volume, what we all practice, and we think, no, this is the norm. 6 ml per kg is what we do it. So is it really true? Do you believe that's the thing, or we have to go forward and still there's something which are missing the link in that?
Yeah, I think this is an excellent question. I think the use of tidal volume or low tidal volume, 6 to 8 or 4 to 8 or maybe 6 milliliters per kilogram predicted body weight, started around 2000 when this big study came out, the ARMOR trial, that showed that there was a huge advantage of using 6 versus 12 milliliters per kilogram of predicted body weight. But we have to realize that that was a complete other time. Patients were deeply sedated. Most of the patients, if not all, were paralyzed for many days, and it could be a complete other group of patients than we have nowadays. And to add to that, we ourselves performed a PREVENT study a couple of years ago, published in the JAMA, in which we also compared low versus high tidal volumes, in this case 6 versus 10. In non-ARDS patients, but patients at the risk of ARDS, we found no benefit of using a low tidal volume. And even worse, very recently, there was the PROLABI study, which is patients that were receiving ventilation because of acute brain injury. In this study also there was a comparison between low tidal volumes and high tidal volumes, and surprisingly, low tidal volumes resulted in harm in these patients. And the major difference between these three studies is the respiratory system compliance of the patients. In ARMA, it was low. In PREVENT, it was intermediate. And in PROLABI, it was actually high, which is giving the suggestion at least that when you have a severe ARDS or when you're severely ill, your lungs are stiff. So say it's maybe better to use a low tidal volume and not in the upper scenarios. And an explanation could be that if you look at the compensation for the low tidal volume, which is a higher respiratory rate, may be the harmful factor here. So if you are having severe ARDS, low tidal volume at the price of a high respiratory rate is maybe acceptable, while in a patient having normal lungs or healthy lungs, the price of a low tidal volume and therefore a high respiratory rate could actually be harmful if we realize that the respiratory rate is part of mechanical power.
Yes, so as you said, tidal volume versus low versus high tidal volume, and still we are not really successful. So I think there's some missing link where we need to improvise. So what is that? What is you think we can do further to have the better outcomes in these patients?
I think that one of the things that we often forget is to set the respiratory rate right. And as we all understand, if you're using a low tidal volume, you have to compensate with a high respiratory rate. And the price of a respiratory rate is a rise in the mechanical power.
Oh.
And of course, if you have a patient with a very damaged lung in which you need to give a low tidal volume because of its benefit, you can accept a higher respiratory rate. But in the other scenarios that I described, it could be completely different.
So it's like hitting someone once and hitting someone 4 times is going to cause more harm. So it's the same kind of thing.
Could be. And there is also evidence for that now. But this is all retrospective evidence or meta-basis evidence. But it's all pointing in the same direction. The higher the respiratory rate, the worse the outcome of a patient. So I think we as clinicians have to realize that and actually need to do newer studies in which you say, is it better to use a lower respiratory rate, maybe even accepting hypercarbia in some of our patients to reduce the mechanical power and with that reducing the harm caused to the lungs of the patients.